Hi, everybody. This is Glenn Woodworth from the Society for Education and Anesthesiology. And today it's my great pleasure to have Garrett Burnett with us for our webcast series on innovations in anesthesia education. Dr. Burnett is an assistant professor and he's the director of operations of the Sinai Simulation Center at the Icahn School of Medicine in the Department of Anesthesiology, Pain, and Perioperative Medicine. And his title today for this talk is Ultrasound Anatomy and Procedural Training Using Freedom Art Embalmed Cadavers. Now that seems to me like an appropriate topic for an October webcast. All right. Okay, Garrett, welcome. Thanks so much for joining us.
Thanks for having me.
Well, what I'd like to do is I'd like to start out, and I always like to try and understand, what got you involved in this project? What was the piece of sand that turned into a pearl? What was it that got you going?
Sure. So I'm a regional anesthesiologist by training. I completed a regional anesthesia fellowship at Mount Sinai. And so one of the things I'm most interested in is regional anesthesia, but also simulation and education. So my colleague and I, who's also a junior faculty in the department or division of regional anesthesia, Chang Park, we're interested in finding better ways that we could kind of educate our residents and fellows on procedural technique, but also just functional anatomy associated with regional anesthesia. And one of the things that got us excited was the idea of trying to use cadaver-based training, which is something our department hadn't done to this point.
Okay.
So we were really looking for ways that we could use kind of hands-on training outside of the operating room or outside of the sim lab for our residents and fellows.
So how did you get started?
Well, we got started because one of our CA1s it might have been CA1s at the time had been a teaching assistant throughout his MD PhD program at Mount Sinai. He had been a teaching assistant in the anatomy lab. So we started out kind of ahead with him, just because he was so familiar with the anatomy lab and familiar with teaching anatomy. So we got together with him and wanted to come up with a course that we could develop for our residents. One of the things that we were looking for was to try and find some kind of prep that was the most lifelike we could, so to make it as realistic as, well, I guess as in lifelike as possible for anatomical scanning as well as for procedures.
So when you say that, you meant the cadavers had to be in such a way that you were actually going to do live ultrasound scanning on the cadavers. You weren't actually going to be dissecting these cadavers to do so.
Well, we were going to be doing both. So the goal was that we would be able to more easily scan the cadavers on ultrasound, perform the blocks, and then further dissect out those blocks and compare that to the ultrasound anatomy on the contralateral side.
Okay, awesome. Now, is that so? You might already have. You would have, if I understand it correctly, you do one side where you do the scanning and the needle placement, and the other side you actually have dissected out that you could go to examine.
So we actually did scanning and single shot blocks with methylene blue.
Okay.
Or we would use a catheter technique, whether it was interscaling catheters or neuraxial catheters, and then we would actually dissect out the block side. So the nice thing there is that we can actually see where the dye spread, just like many anatomical regional studies where they're just looking at how the dye spreads during blocks. This allowed the residents and fellows to really see where the block goes and physically see the stained brachial plexus to see that, oh yeah, we do hit every chord when we do an infraclavicular block.
Okay. Well, let's talk a little bit about logistics. How many residents were going to be in a session?
So
residents and fellows.
Yeah, so our goal was to have around 8 per session, with the idea that not all of them would be dissecting or performing blocks all at the same time. Everyone had their own kind of comfort with dissection. Most of them hadn't done any cadaver-based training since they were first-year medical students. So we aimed for around 8. That way, half the group could be kind of working at the upper part of the body, the half of the group could be working at the lower extremities. And that gave enough people hands-on experience while also trying to make sure we had enough participants be able to participate.
Okay, so you're going to do 8 participants, and how many cadavers are you going to have for each session?
So we had one per session,
Okay.
and we did it Monday through Friday. We have a pretty big program here. There's 26 residents a year. So in order to try and capture as many residents and allow them to participate as much as possible, we did it for a week.
Okay, and then how long does the session last?
It was all day. So
All day. Okay.
yeah, so
you'd have 8 participants for a whole day.
Exactly.
Okay, and I assume you only had how many blocks did you do, and which blocks did you focus on?
So we did a mixture. So we focused on the basic blocks such as like interscalene, supraclavicular, infraclavicular, axillary, adductor, femoral, and top. But we also, I mean, the first iteration of this was in March 2020, kind of prior to COVID. But we were interested in kind of these emerging blocks. I mean, ESP blocks at the time were still very much new and hot. So a lot of our residents hadn't been doing them, but this allowed them to do an ESP block on a cadaver, dissect it out, see where the dye goes and things like that. So we were pretty open to block techniques that the residents may want to try. But we really focused on the main kind of core blocks.
Okay. The reason I'm asking is I'm trying to get an overall structure in case somebody in our audience would want to try and replicate what you've done. So I'm basically trying to give them all the aspects of what they would do. So
yeah, so one thing that I would recommend if somebody was trying to replicate it would be that, like I said, we had half of the group at the upper part of the torso, half the group at the lower part of the extremities, and they would kind of each do the block and then dissect out, and then the one half the group would kind of teach the other half, kind of take them through the block, take them through the anatomy that they find, and show all the structures that they've dissected out, and then the other group would kind of swap and do the same for the lower half.
Okay, so you had was it a little crowded to have 8 people around one specimen and trying to be up and below? And
it was kind of dependent on how involved the residents were for each day. So occasionally it was pretty cramped, and with the second iteration in March of 2021, we kept it more down to 6 just for social distancing purposes. So that was a little bit less crowded for sure, but it kind of depends on how involved the learners want to be. Some of them just kind of wanted to observe and then learn once the dissections were done, whereas some wanted to really really kind of get gung-ho and
get into it.
Yeah, exactly.
Yeah. Now, I also can think of a little bit of logistics things is when you have to turn a body, to be able to get it in position to do, let's say, the popliteal or ESP to try and get it in a prone, or, that's actually a little complicated to do. And it might disrupt your flow because if you turned him, I don't know, let's say prone to do the ESP, I don't know what else you would be able to do at the same time. So I suspect that might have been a little bit of a challenge.
So what we actually did was we started prone, and we kind of went through neuraxial initially. So thoracic epidurals was one of the ones that most of the residents hadn't done before, so they were very excited to learn the anatomy there. So that was kind of everybody together as a group.
Got it.
Then some of the group would be practicing ESPs or scanning for paravertebrals, while the other part of the group was doing sciatic popliteal blocks. So that kind of gave everybody something to do on the
So we kind of glossed over it, but we tried to do this with your early trainees, your CA1s. Did it matter what time of year? Did you try to do it within the first 3 months, or at what point in their training did you attempt to do this?
Yeah, so ideally we would do it at the beginning of the year. I think that there'd probably be a lot of benefit in getting some of that anatomy up front. unfortunately, since we're doing it at the anatomy lab, the first year medical students are kind of take priority for that for the
Yes.
anatomy lab. So
Yeah, it's common for wanting to use the anatomy lab is to try
right,
and you have to share that space.
yeah.
I've got another question though that I think about reproducibility of this is you need to have some faculty members. So it probably took two faculty members, I'm going to guess, one for the upper and one for the lower. Would that be right?
So we did this with, like I mentioned, our resident who had previously been a teaching assistant, Patrick Mafucci. We couldn't have done it without him. I think at this point we've definitely gotten to the point where Chang and I both feel more comfortable there. But
You
starting,
have, I guess I'm sorry to interrupt you. I know I'm gonna come back to the anatomical experience, but you at least had to have a regional faculty member, of one.
yeah.
I'm trying, how many did you have? Just one or two?
So the first day we had both Chang and I were there just so that we could kind of get used to the course. And then just because of scheduling availability, it was pretty much just one of us each of the subsequent days.
Okay, the reason I said that is I was thinking about, somebody in the upper extremity doing a block and simultaneously somebody in the lower extremity doing a block.
Oh,
Um,
well, we would do the block and then they would start the dissection and then I would move on to the other.
oh, I see. Well, so in other words, you'd do the block, they'd start the dissection, let's say the interscaling, then you'd move down to the lower extremity because the dissection is going to take a while.
Exactly. Exactly.
Okay. And then you had your anatomist teaching assistant who is
Yes.
able to assist with the dissection
Mhm.
because it's actually, you have to be fairly careful about how you do the dissection so you don't
Definitely.
destroy things. And there's also different techniques on which way the incision should be, which flap do you raise to demonstrate that your anatomy. So you needed to have an anatomist, a teaching assistant at least there to assist.
Yeah, and even doesn't necessarily have to be somebody within the Department of Anesthesia like we had.
Yep.
I
Yep.
mean, anybody that is familiar with anatomy would definitely be able to help. I think just planning ahead with them so that they know kind of what your goals are would be beneficial so they can kind of help give you the best advice
Right.
to get it done.
Sometimes it takes a little while to do a nice dissection. So I'm wondering, was that enough time in one day for them to be able to, to do all of these blocks and complete? That's a lot of dissection to complete actually in one day.
No, it was, and we found that it we weren't doing. I mean, we're not doing pro sections, but we were able to identify all the relevant anatomy that was important for each block. So while I agree it does take a little bit of time and some blocks took longer than others, we were still able to get it done.
Okay, great. I just could see that. I know when I'm doing dissections, it could take me, an hour just to remove the skin and fat on an area that I'm getting started. So I can see that as a little bit of a challenge. All right, here comes my next question.
Okay.
At least at my institution, getting time in the anatomy lab, as well as cadavers. Sometimes you could be charged for those at your institution, and one cadaver could easily be a couple $1,000s. And so if you did, you would need that 5 times. You were talking, $10,000 potentially for some of us to run a
Mhm.
similar course. So that's my next question. How did you get? Did you require your department? How supportive were they? What level of funding did you need?
Yeah.
Can you tell us a little bit about that?
I will say that our department and our residency administration were very supportive of the initiative. And I mean, I do definitely recognize that it can be very expensive to have time in the anatomy lab and to have cadavers. We were not charged for the anatomy lab time, but we were charged for the cadavers. So I could see that definitely being an obstacle for some institutions.
Okay. And with these particular prep that you had on the cadavers, the Freedom Art, was that less expensive, or what was the reason for using that versus sort of fresh, thawed or frozen thawed?
Yeah, so the traditional cadaver prep is generally going to be a formaldehyde formalin prep, which oftentimes will lead to pretty stiff joints, stiff tissues, um, some difficulty with ultrasound visualization of relevant structures.
Definitely.
And the nice thing about this Freedom Art prep with it is it preserves some of that flexibility and the tissue is much more lifelike. And subsequently, we were able to ultrasound it prior to the course because they did already have a cadaver with that prep. And we were able to visualize all the structures we needed to, and it looked very realistic and lifelike. So
Excellent.
it turned out to be very nice for that. I mean,
Okay.
I think what you're saying, either a fresh or a frozen fresh cadaver would probably be much more ideal, just because it is even more lifelike. But the availability of those cadavers, my understanding, can be difficult to come by.
Okay. Yeah, and I don't know if there's a difference in cost actually.
Yeah, I
Uh,
don't either.
yeah. Okay. All right. Well, this sounds like a great project. Tell us a little bit about, did you do anything in terms of uh, measurement of results, or, how did,
Hmm.
satisfaction, knowledge test, did you do anything in terms of measuring the results of your intervention?
Yeah, so we did more formalized testing as far as like a pre-course test and a post-course test based on regional anesthesia anatomical knowledge. And we did show that based on kind of our preliminary data that we've looked at so far, it's about a 20% increase. We haven't done any further statistical analysis on it, but about a 20% increase in post-test scores, as well as some subjective, uh, not, how did you feel that your like rate 1 to 5, what was your knowledge of peripheral nerve blocks and comfort of the anatomy associated with that? That went from about a 3 to a 5 after the course, and the same question, but for neuraxial, went from about a 4 to a 5. So across the board increases, much more for the peripheral nerve block than the neuraxial anatomy. But um, and then we also just kind of got subjective feedback about what they liked about the course, what they didn't like about the course, and just one anecdotal evidence that we had was a CA2 had never done a thoracic epidural. The week after the course, they were able to do their first one, and they said that it went very, very smoothly because they knew they had just done one during the course, and they were much more confident, and it went very smooth. So that was
Awesome.
good to
You might
hear.
hear my dog barking in the background. I apologize.
Wow,
COVID,
you might have heard my pager, so it's okay.
it's the year of COVID. Um, Now, are you going to try to publish these results?
So we're trying to do two things. One, we're trying to publish the data, but we're also trying to write up the curriculum for a medical education journal like MedEd Portal or some kind of curriculum sharing platform.
Yeah, one of the, so you might have, in terms of, I don't know what your thoughts are in terms of including for your curriculum, but obviously your objectives, your learning objectives that you were after, and how you would measure achievement in those learning objectives. But also, I suspect that there'd have to be some information about the anatomical dissection. Uh,
Hmm.
how much you did, what target structures you wanted to show for each thing. And if you have any of that, we at the SCA like to publish that along with your webcast. And the reason for that, again, is we like to try to achieve some level of transferability. So if anybody also wanted to try this, do they have enough of the tools so they can do it? So post of this webcast, after we're finished, I'll ask you to send me whatever material you're comfortable with.
Sure.
Now, in terms of the publication of the data, the pre and post data, so this is a common thing that comes up in education research, is that people develop a curriculum or a course, and then they have to demonstrate some sort of outcomes that they want to then do some statistical analysis on, and to aid them in their publication. So the challenge becomes, is what do you use as a control group? So
Yeah.
you might think about just a pre and post as being, hey, my pre was my control. And
Yeah.
then my post, look at, they got better, and that's obvious. But really what's meaningful is that's compared to nothing. What
Exactly.
would have happened if you had a control group that watched some videos, or you had a control group that just had to read a bunch of stuff? That we don't know. And so that helps us, the way you design the control group is more helpful in determining the effectiveness of what you're doing. And it's a little tricky, I might add, trying to decide
Yeah.
what is the control group. The second thing that becomes super interesting in when you try and design your outcome analysis is this concept. We'll talk about the soft things later, which are, you know, satisfaction and things like that. But let's talk about the technical knowledge achievement. And
Mhm.
so, to really publish in a high quality journal, the reviewers are going to question, how did you develop the pre-test and the post-test? So most people forget about that step. They just think, well, we put together little questions, and, you know, and here we go. And they got 7 right on this one, and they got, you know, 90% right on the after they were done. Yeah, ta-da, we did great.
Yeah.
But if you try and publish in a high quality journal, they're going to question. So you need to have something in your methods section and describing, you know, how you actually went about, and how you convened a panel of experts. They identified these were the things that, you know, the knowledge that need to be achieved. Those were then turned into questions. We did a pilot study where we give these questions to some people. We showed that people that didn't have very much experience didn't do well on our test, and the people that had a lot of experience, like our fellows and our senior residents and our faculty, did great on the test. Okay, so we have some sense that the test itself is valid, or the assessment method is valid, and then that can be applied in your study. So I just wanted to go through that. I've had a little bit of experience in myself by that, and I just wanted to go through that so people understood that, because this is a very common problem when you do an intervention, is trying to prove some outcomes, because your chair usually loves it if you're also going to publish your results.
Sure. And that was one of the things that we've talked about a lot over the last year or so. I mean, this started as more of an educational initiative rather than a research study. So we felt like withholding the education, even temporarily, to allow for a control group might be kind of at a detriment to our residents and fellows. So while we recognize definitely that we don't have that control group to actually compare it to, and
Yeah, and make sure that you know, I'm not trying to be critical of your study. I'm just trying to point out
not at all.
this is a common experience. And also, that argument that you used was, we didn't feel like we could ethically do this, you know, and not offer this. That sort of a priori assumes that the activity and everything that you're going to do is better than some other methodology.
That's
So
true.
another common research approach, where you don't want to sacrifice an experience, is to do a crossover methodology, where
Yeah.
you'll have half of the group will take intervention A, and then after a period of time they're going to do intervention B, and the other group is going to be a crossover group. They'll do B first and then A first. So maybe A is the reading part of it, or watch the video or something else,
Yeah.
and then the B part of it might be the actual intervention. That's another way to get around that particular concept, and also
Yeah.
to give the reviewers an opportunity. The other thing that I would point out to junior faculty is, you put a lot of time and effort into creating that course and fine tuning it. And you know what? It is easier to just do that and not publish it. I admit that for sure. However, if you can take that extra 20% of work, it's probably more like 50% if I was honest.
Yeah, we'll call it 20.
Yeah,
So
we'll call
people
it
will see
20. You know, to try and get an extra bang for all that work you did, to get some sort of publication
Yeah.
out of it. When you're looking at your CV in terms of advancement and promotion, you will get credit for things that you do locally, but you also were looking for, when you're getting to the associate level, that the things that you're creating have some sort of broader dissemination. So either at a regional level, or even on a national level. And so by publishing your results or your curriculum, or showing that you were able to demonstrate that other groups have adopted what you've done, that helps demonstrate that. And also, this participating in a webcast like this also helps in that way as well.
Yeah.
All right, now you mentioned briefly, after that little discourse on education research, I apologize, but that's part of what these webcasts are for. I wanted to ask you a little bit about, you said you got some feedback about things that people liked and they didn't like. Can you share a little bit more about, you know, what kind of feedback you got?
So I'd say by and large, most of our feedback was positive. They enjoyed being able to do the hands-on. Some of them had never done some of these blocks before, so getting the experience of doing those blocks prior to the first time they're doing the block, with their attending over their shoulder and a patient right there. So they were really glad that they were able to do that. I think the biggest complaint that we got was that in order to allow residents to be there and as many people to participate as possible, as a lot of them were doing this course pre-call to allow them to
Right.
the operating room. So that was kind of the biggest complaint, and honestly, availability of staff to teach and residents to participate was by and large our biggest limitation of the program.
Right. I can see. So some of the programs that have like a dedicated education day,
Yeah,
um, might benefit from that. I can see,
definitely.
yeah, I can see that as a big challenge,
Mhm.
both for staff, getting staff free and getting the residents there.
Yeah.
Right. Okay. Great. Were there any other challenges that you felt, that you had to overcome to try and get this thing done?
I mean, I think COVID has been a challenge for every type of educational program over the last year and a half or so, and luckily the first iteration of this was just before that became a reality in New York City. But since we've been doing it annually, and we plan to continue doing it annually. And last year it limited the number of people that we could have around, and uh, just staffing issues and just making sure that we had enough residents that could be out and attend the course, and enough faculty to help run it. That's definitely been another barrier.
Well, so I have a couple of other concepts for this. I'm a regional anesthesiologist by training as well.
Hmm.
And what I think one of the novel things that you did, at least I don't think I've seen it done anywhere else, which I really like what you've done, is I like you doing the block and then injecting some dye and then doing a follow-up, quick dissection,
Hmm.
right on top of it. I think that's a fantastic idea, great innovation.
And
I don't know if that's something you guys came up yourself, or is that something that you just figured, you saw it in the literature where people do that for research studies, but I don't
exactly.
know in a cadaver course that people do that on a routine basis. So
Yeah, so I mean, there's anatomical studies that are looking at blocks. Most oftentimes they use methylene blue to show how far the local, like the upper limit of how far the local could go, or they'll use like latex or a plastic to see the kind of the lower limit of how far that local could spread. Obviously, injecting methylene blue is going to be a lot easier for us, so that's what we chose. But I thought it would be a nice concept to actually see where our local ends up. And then you also have, say, we do the block on the right side. They can then scan the anatomy on the left side after they've done the dissection and compare what they're seeing with their eyes to what they're seeing with the ultrasound.
yeah, I
Yeah.
think that's a great technique. I have another suggestion for you. Is Of course, do you put any regional anesthesia courses on for your community physicians?
We haven't yet, but that is one thing that we've considered and we've discussed. We do quite a bit of MOCA courses in our simulation lab, and so we have experience providing educational courses for the community, and that's something that we're looking into for the future.
Yeah, I'm just thinking in terms of funding, because if you do this in the community, it's possible that you can use some of those funds to help pay for the cadavers that you're using in your regular residency
Yeah.
course. And also, you may or may not be able to get some industry funding for it's much more difficult these days to do, of course, but you may be able to get some industry funding for some of the cadavers that you're using. Um,
Definitely.
I don't know, let's say you're using the pi junk needle, and who knows that they'd be able to do it, or you're using, somebody's ultrasound machine, they might be able to help
Yeah.
you. I'm just thinking about ways that other programs might be able to offset the funding.
And
But I,
I have helped teach at cadaver-based courses that have utilized that method, and
yeah.
so it definitely is something that can work.
Well, I know we've used it here about putting on that exact same course that you did. You just replicate it for some physicians in the community, and then you charge them, and then you can use that funding. So I know I've used that method fairly successfully to try and get some projects
Yeah.
funded.
And one other way that I think that people could kind of overcome that cost barrier is by linking with other departments that may not necessarily be using that same area of the body, and kind of going in on cadavers with, say, neurosurgery, who wants to use the head of the cadaver. We want to use the leg of the cadaver, so that allows kind of cost sharing.
Yeah, that's a great point. I thought about that, but I didn't know if that would be applicable in what you were doing because you're working all over the body,
Yeah,
and
well, I
that
mean,
would be a little bit more challenging.
I think adapted versions of the study for those who don't necessarily have the resources that we had. could make some kind of educational opportunity for their trainees happen.
And then the other thing that you can think about is you can assist your university by creating a pro section, an embalmed pro section that they can keep around and that they can
Yeah,
use for medical students, but you can wheel that out next to
yeah,
the cadaver that you did the fresh dissection on. And so if you can look at a little bit more detail and you've got things tagged, that might be something that you could add to your course as well.
and honestly, to that point, Patrick, who is a very, very good dissector, did a pro section of the airway, and we have that. That's from a traditionally embalmed cadaver, so we are able to bring that out throughout the every iteration of the course, and it really shows the airway in a way that we're not familiar with seeing, but it really helps you appreciate kind of the posterior pharynx, the glottis, the chords, and below the chords as well. So,
All right, well, let me get a piece of paper because I want to try and write Patrick's name down and try and steal him, poach
yes.
him from your university. Sounds like a great asset. I want to remind everybody because I didn't want to gloss over that one point that Garrett just made is that is you often, if you form a good relationship with your anatomy lab, they will notify you when other departments are using a cadaver and not using, and there will be a part of it that you can still get access to,
Yeah,
and they won't charge you at all in that case to come in and use that extra piece of the cadaver. Of course, unless they're charging you for time. But that was a great point, and we use it frequently here, and I think that's a great point for everybody.
yeah, definitely.
All right. Is there anything else that you want to let our audience know about this project?
No, I mean, I imagine that my contact information, or at least my email, will be made available. Email me if you have any questions, and I'll do what I can to help.
All right. Well, fantastic. Again, I want to thank you so much for sharing. I think this is a really unique and interesting project, and I think quite valuable. So thanks so much for joining us today.
Thanks for having me.